Great. So if we don't have any other questions then about the strategic plan, then we will move on to our 2 State of the Science talks. So we are very honored to have here today Heidi Rehm and Mark Williams, who are going to be giving 2 separate versions of the State of the Science of Genomic Medicine today. What we're hoping to be able to do in these 2 presentations is to be able to get everyone on the same page with where do we stand now? Where is genomics medicine in the community today? So that as we continue to have our discussion over the next 2 days, we can start thinking about what do we need for the future to be able to make this implementation even better. So I'll turn it over to Heidi. Thanks.
Thank you. It's great to be here this morning. Let's see if I can figure out Terry's tricks to this. There we go. So our Mark and I's task for this morning was that we had 15 minutes to present on the current state of genomic medicine from our perspective. When I was asked to do that, I didn't think hard about it. And then a few days ago, I thought, oh my God, what did I agree to? How do we sum up all of genomic medicine in 15 minutes? And how much time is it going to take me to put this talk together? And this is about where I was when I started. And sadly, I think it's about where I was when I ended, which is this is going to be a bit of a roller coaster ride. This is actually a roller coaster statue in Germany. I found a lot of things on the internet during the course of this talk. And I don't know what happens when you get to this part of the walking tour, but I tried to figure that out. So anyway, I'm going to sort of take a roller coaster tour through genomic medicine. Along the way, I'm going to attempt to identify the challenges and work yet to be done. And if all goes well, we won't end up in this state by the end. These are real pictures of real things that happened that I found. They only had the ones that were captured on camera. God, what else happened on roller coasters? I will never ride another roller coaster. By the way, these people have flown off of this, and I don't think that ended well. So anyway, hopefully we won't crash and burn, but on to the actual meat of this talk. So as I was thinking about sort of the state of genomic medicine, I thought about it in 3 ways in terms of the core work and building blocks of genomic medicine. So I think we continue to focus in discovery. It's a core element we have not obviously discovered all we need to discover to support genomic medicine. And this has moved really from just basic science into real, learning healthcare systems where we continue to discover in real time as we move on with our work. Obviously, critical to rolling out genomic medicine is the evidence of utility of the things that we discover and how we bring it into practice. And then I think probably in my mind, the biggest barrier we have today that we need to focus on is really the implementation side of this. Now, critical to all of these things are all of the sort of tools and methods, the standards and the knowledge bases that we are building and need to build to support all of these domains of work. So I'm going to try to tackle a little bit, not all of it, in each of these areas as we go along. So to start in the discovery sort of side, as I mentioned, I feel that there's increasing integration of clinical care and research, really trying to realize this learning healthcare system. And so although I'm not going to cover all areas of discovery in genomic medicine, I'll just give a few examples where I think discovery interfaces fairly closely with clinical care. I think the eMERGE program is one example of that. I think the Centers for Mendelian Genomics and the UDN program in the rare disease space are a good example. And although I won't talk about it here, clinical trials in somatic cancer is just a constant interface of research and clinical care. So on my one slide on eMERGE, it's a big program. To date, there are over 136,000 biobank participants across all of the participating sites whose data has been and being collected to inform many of the discoveries being made in the eMERGE program. There's been a huge focus on the collection of phenotypes from electronic health records. And in the 3 phases of eMERGE that have happened to date, there are over 70 phenotypes that have been defined. Now that may seem simple, like collecting 70 phenotypes, but we're really talking about trying to derive overall diagnoses out of EHR data. And so the development of the algorithms to really try to extract accurate diagnoses from EHR data has not been a simple task, but through phenotype knowledge bases that have been developed through these different phenotype algorithms that have really then supported the discovery of relationships. And to date, there's impressive over 26,000 papers that have come out of eMERGE. So I think a really great program. Now, as I mentioned, I think some of the challenges to the development and phenotyping of our patient population, a lot of the phenotyping in research can be highly comprehensive, but it's also labor intensive. It suffers some challenges in recruitment when you're doing this outside in a research environment, and certainly resource sustainability to deeply phenotype in research studies all of these patients. So we have to move into real-time clinical care. However, phenotyping in healthcare, while it can piggyback on EHR data collection, it's often dependent on indirect information. And this is a diagram I stole off the eMERGE website, where we're basically pulling data from billing codes, clinical notes that have to be processed through natural language processing, lab and test results, prescription of medications. And while these, phenotype algorithms that have been developed have actually been a lot of work and fairly robust, it's not straightforward to try to get at accurate overall diagnoses from all of these sort of indirect types of methods. And I will argue that it is not well developed for rare disease diagnosis largely. So I think, we've come a long way, but we still have, I think, a long way to go to really make use of our clinical care system in informing the phenotypes of individuals. Jumping over to the rare disease side, this is a paper that Mike Bamshad, Debbie Nickerson, and Jessica just wrote a few weeks ago, showing just impressive rapid gene discoveries that have been happening over the last decade or so. I had to capture a quote from the council NHGRI council session: "The CMGs have been wildly successful." I agree. Keep funding us, but more seriously, although lots of progress has been made, I would argue that patients being tested for suspicion of rare disease receive a diagnosis well less than 50% of the time. And this was just a figure of diagnostic rates across different disease areas. And these, I would argue, aren't even the challenging ones. I would argue, probably only 20% of patients that are getting diagnostic testing for suspicion of rare disease actually get a positive diagnosis. We then take these negative cases and push them into the Centers for Mendelian Genomics. So at the Broad, we solve about 30% of those negative cases that come in. About half of those solves are known disease genes that were missed in the clinical testing, not just because they literally made an error. A lot of times it's just the length of time when their original test was done versus when we're looking at it now, or they didn't look at all of the relevant genes, things like that. And then about half of those are, in fact, novel gene discoveries. But I would argue we are still leaving many, many patients on the table without a diagnosis. And so we do have a lot of work to be done in the space of rare disease diagnosis, which is frankly the easier side of the diagnostic spectrum. Moving on to the evidence of utility. This is critical if we're going to rationally justify the integration of genomics into the practice of medicine. Sharon Plon and I have been working on a figure, mostly Sharon's work, looking at sort of modes of clinical utility. This is to go into a review that we're part of. So, looking at areas for diagnostic clinical utility in this case, where we can really justify the use of genomics because it can point towards the use of targeted therapeutics, prophylactic interventions, increased surveillance, or even altering diet or behavior. And these are all, examples of diseases and their genes and the interventions and screenings and other modalities that really justify the need to make a genetic diagnosis in these different disease areas. And in terms of population screenings, that was more patients with a symptom and how we can justify the use of genetics. For the healthy population, the question of the clinical utility for population-based based genetic screening. I think we have, areas that are clearly been in use, cystic fibrosis for preconception, in the prenatal space, the widespread use of non-invasive prenatal screening now. Obviously in newborns, we have blood spot-based newborn screening. And now in the adult space, really following on the CDC Tier 1 diseases for breast and ovarian cancer, colon cancer, and familial hypercholesterolemia. I think there's good evidence in all of these areas. Use of piggyback testing, I would call it, ACMG 59 genes, while all of them might not meet quite the clinical utility evidence yet, by piggybacking on top of existing exome, which was the argument in that original ACMG recommendations, and also wider spread use of expanded carrier screening. If you're already doing CF, why not throw on the rest? So ways that we can make use of expenses already incurred but add additional value will help us sort of head there. And I haven't captured all of the evidence, but here is just one recent paper in cost effectiveness analysis for population health and screening, where they argued that it was justified based on this cost effective analysis. I think this is from Australia. Moving on. I think some of the challenges is it's difficult to demonstrate clinical utility for most monogenic diseases given their rarity. And certainly the incentives for drug development are diminished given small markets in this space. But I think there are solutions, demonstrating utility of genomic testing in aggregate populations, whether it's the entire rare disease population or at least, different subsets, multiple congenital anomalies, neurodevelopmental disorders, pediatric population, the NICU population. So trying to define populations as opposed to for every individual rare disease or phenotype is the way probably we're going to have to, document clinical utility. And obviously, the more we can focus on development of therapeutics that can be easily adapted for many different targets, I think will help, enable patients with these diseases to get access to therapeutics despite the incredible rarity of many of these conditions. Moving on to clinical implementation. The nice thing is clinical genetic testing is widely available with pricing that's now accessible, I would argue, to most of the population, not all. And this just stolen off of one of the many genetic testing websites, in network for over 250 million people, transparent pricing including $250 patient pay option for pretty much everything. Most patients pay less than $100. So for panel-based testing, it's fairly widespread in accessibility. But despite the fact that we have these available, actually getting these tests into the hands of patients still has many barriers, I would argue, because of implementation challenges. I left as the director of a clinical lab a little over a year ago, and part of that was the frustration that I was at a lab that we could do everything all the way to whole genome sequencing, but the actual getting those tests in the hands of patients was not happening effectively. And so I moved into the hospital arena to work with clinicians and the clinics directly to try to figure out how to better support the implementation of these tests. And although you can't see this, is me meeting with all the different specialties and asking them what are their current genetic counseling support, what do they want, what's their current genetic testing, but what do they want, and identifying all the gaps there. And I would say that there are certain specialties that are super users of genetics, but there are others even in major academic medical centers that are still learning how to do this. The physicians are overwhelmed with so many labs and tests to choose from that are not standardized, and they just don't know what to choose, and they need help. And billing and reimbursement is still a major barrier. In our world, the success is ordering outside the hospital system and using the commercial lab billing because our hospital can't support it. And we still have patients that if they go through the hospital end up with like $25,000 bills when they could have paid the same test out of pocket for $250. That's ridiculous. It's still happening in my hospital. And of course, when they've figured out the system, which is just to go outside the hospital and order it, that's great. They can now only pay $250 or less, but there's often no record of testing the EHR except if you're lucky enough to get them to scan the PDF and stick it in the media tab, right? This is a major problem. Also, there's a huge burden to our genetic counselors and the physicians in doing the prior auth. It's taking like an hour or two per patient. So a whole new career has now been launched, which are these genetic counseling assistants. I just hired one. She starts Monday. Our cancer center has already hired, 2 of these. They're just working with the GCs to put in and do all the prior auth and things like that. Because now with the cost of genetic counselors, we can't afford to have them doing this stuff. And so these are like implementation solutions that to a generally challenging environment. The genomic approaches, so most testing I would argue today is being done largely by panel testing with maybe some exception, particularly in the neurodevelopmental space, but that is moving more and more to exome. But genomics can yield higher detection rates, but they do cost more, and their utility really depends on comprehensive phenotyping analysis. We recently completed a demonstration project at MGH where we had 100 symptomatic patients from 7 specialty clinics randomized to either standard of care or standard of care plus WGS. 18 diagnoses were made. All of the 9 from standard of care were also made by genome, but we made an additional 9 by whole genome. 6 of those were for the primary indication, 3 were for secondary indications. And this was partly because we went through the medical record and we extracted all of the phenotypic data, most of which the clinician hadn't given for their indication for testing, and we found answers for other phenotypes in there. So that's, in my mind, what we really want to do to make use of genomics, but it requires an incredible effort with genetic counselors going through the medical records to do this. How do we support that in a higher throughput way in routine practice? And it also took a long time looking through all the genetic data to find these diagnoses. And I would argue patients still have concerns about genetics in their care. This is reasons for decline of exome sequencing in our BabySeq study, still major concerns over insurance discrimination, privacy, and even just getting unfavorable results for their newborns. So tackling some of these issues are things we still have ahead of us. Now, I also think we need to think creatively about how we support all physicians in offering genetic care. And there's a number of institutions, and ours included, launching e-consult services within the electronic health records sort of system. This can reduce referrals, and it can help educate physicians in real time as they're seeing a patient and to recognize indications for genetic testing and guide what test to order. So we just literally launched this at MGH 2 weeks ago, our MGH Preventive Genomics e-consult service. Our first one was a patient whose mother died of ovarian cancer and was asked about genetic testing. The PCP recognized that this patient was appropriate for genetic testing, but basically said to us, I have no idea which of these thousands of tests on the internet to order and from what lab. Can you help me? And that's a real opportunity to reduce costs by not making them send to another referral, but just in real time help this physician. Okay, here's a test that we recommend from this lab, and here's how to order it, and here's some key things based on whether the result comes back negative or positive, and when you should refer, and what are the key things if they're negative. And we were able to, create our first template for that question. That's 2.5 minutes left. Is that the 20 or the 15? Oh, okay. I need to end. Okay. I'm going to just skip through. Physician education's critical. We're on the roller coaster now. Real critical issue in implementing pharmacogenomics. I just give you one thing in talking to clinicians. There was a couple departments that were ordering routinely individual PGX tests for single indications. I said, well, you might consider ordering a panel and getting the rest for free. And he said, no way. Don't want the liability of the other results. Great. So, that's a real barrier. Why? Because there's no clinical decision support in the EHR so that when that patient comes in later, some other physician will know that information. Okay, we need to update genetic information over time. We're definitely on the roller coaster now. We need to structure genetic test results so they can go in electronic record and facilitate clinical decision support. Okay, way more stuff in here than I have time to cover. We can do a genome, but there's major gaps in the all of the different things we need to detect in a genome that aren't really yet rolled out. We argue genomic sequencing is better because it can, in theory, do a bunch of other stuff, but most of the offerings today aren't fully tackling all of these different types of variation that we have to today still use additional tests to tackle. This is our algorithm that was just launched at the Broad to support structural variant detection. It is like very, very complex to get all these pieces to try to effectively detect these. Standards, critical. I've been involved in the Global Alliance for Genomics and Health to try to create standards so that we can actually do so much of what we want to do. A great example of the sort of newer model of federated data sharing is the Matchmaker Exchange, a critical tool for rare disease gene discovery where we can now put in a gene and find the other few patients around the world through a federated matching approach. Knowledge sharing is going to be critical. It is already critical, and it is helping us improve the results we give back to patients. I think this is my last slide. Data sharing has come a long way, but we still have a long way to go. Not every lab is sharing data. There are resources required to share with ClinVar. We know it's a barrier. But in Nomad, all the PI has to do is just simply say yes. And then we do it for them. And still, groups are not saying yes. So I will end there. Thank you to my funding sources that support me and all this stuff, and to all the stuff I stole off the internet or from colleagues. So, it was a whirlwind. All right.
Great. So since Terry was brief, we have a couple extra minutes if anybody wants to follow up Heidi's presentation with a question or two or comments. Colleen.
Heidi, how do you pay for the e-consult service?
So right now it's being paid for by our physician organization, and the way it works is if you do a consult, you get $50 deposited in your check. And that's right now being supported by the hospital. How long they will continue that, but they sort of view it as it reduces a referral, and they see it as beneficial in the overall system, so they're willing to do this. What we are working on right now is seeing if we can get genetic counselors paid for that, which right now they've said, no, this is just for physicians. But they have told us that we could change it. Instead of depositing the $50 in the physician who signs off account, we could send the money to the department, and then the department could distribute those resources. So we are kind of working on how, because the genetic counselors are going to do the legwork for each of the replies, but then right now we're going to have a physician sign off on it, and then the $50 goes in their pocket. So it seems not quite useful, but we're working on that. And we're also asking them to start thinking about direct genetic counseling, $50 in their pocket.
On the side.
I don't have a mic. I hope you can hear me. That was fantastic. Thank you. I have a comment about the clinical utility slide you had.
Yes.
I would argue, and I get that I am a little biased because I live in cancer genetics world every day, but I would argue cancer fits in all four of those pie pieces.
Yes.
Under your clinical utility. So I would argue strongly that cancer fits in all four pieces of the critical components of clinical utility of genetics and genomics in clinical practice.
Yeah, and I didn't mean to say it wasn't in all of those. We were just giving some examples, and cancer is in at least, I don't know that it's in diet and behavior, although you could argue it should be in there. But yes, we were just picking things off the internet and sticking them in buckets. We didn't do a comprehensive assessment.
Can you comment on, maybe this is too broad a question, but the chicken and egg question in terms of clinical utility and implementation? We all know that bad implementation leads to poor clinical utility data.
Yeah, it's a great question. And, I think one of the challenges we suffer from, there's things that are obviously useful and already being implemented, and how do we do a real randomized clinical trial in many of these areas, which is really not possible to do. I don't have a great answer to your question. I do see it as we just have to simply iterate, working on both the implementation side and trying our best to be able to do analyses that can demonstrate utility, even though they may not be perfect analyses, because we are sort of in this evolving constant iteration. So I don't have a great solution for you, but I just think we have to work with the system we have and do our best.
Heidi, that was a great talk. I just have two comments and a question. The first comment is, and I totally understand why people may be just having patients pay $250 out of pocket to get their testing done, but I worry that just causes increased access and equity and disparity issues.
Yeah, and I didn't mean to say that's what we're actually doing. So certainly at MGH, I think this is common elsewhere. We are using the commercial lab to do the insurance billing, with the exception of when they won't deal with Medicaid patients. The rest, our genetic counselors and now our genetic counselor assistants are putting in all the prior auth information, and then we are asking the commercial lab to do all the billing, and so most of these patients are not paying they're not doing the full out-of-pocket cost. They are actually using insurance for coverage.
Okay, once their deductibles are met.
Once,
okay.
Yes, absolutely.
Yeah. The question about clinical utility is, the payers have always had this definition of clinical utility as medically actionable, and I think the genetics world has always has broadened that to social utility and personal utility and beyond, and just having a diagnosis. Are there any conversations going on or any work going on to sort of prove that a broader definition of clinical utility?
I don't know the answer to that, but I do think at a minimum, ending the diagnostic odyssey is a cost-effective solution. They've seen anecdotal examples of this, the amount of money being spent on those patients every year trying to figure out what's going on is enormous. So, by getting a diagnosis, a lot of that does end. Obviously, there's still follow-up for the patient once they have a diagnosis. But I think all of these exploratory tests, which are often done over and over, if we can demonstrate the cost savings just by ending that diagnostic odyssey, that alone, I think, should demonstrate economic utility, as well as our arguments for personal utility and other things to obtaining a diagnosis. So I don't think they've really moved on to personal utility being part of the definition, but I certainly think there's some wider arguments we can make besides, improved clinical outcomes, which for many diseases, rare diseases, we just don't have that data yet.
Yeah, well, it's data that you could get at the Children's Service, at the General.
Yes, yes, absolutely.
Okay, I think we have to stop there, move on to Mark Williams. Thank you.